So let's start with this very important module, that is trauma and burns. Lots of questions are asked from this module in various exams. Before we start, please remember that what determines your reality or your success is your focus. If you have a very clear focus, a very clear picture in your mind, you'll do well. But if that picture of your goal is hazy, then your journey will also be more difficult. Okay, so having a very clear focus of vision is very important in achieving your result. So the broad topics which I have covered in this module are the basics of trauma management, abdominal, thoracic, head and neck trauma, and thermal injuries. So first we talk about basics of trauma management, and the questions or the PYTs from this subsection are triage, which has been asked many times, the clinical situations and the color coding, causes of death within 1 hour, that is the golden hour, airway management, the image of cricothyroidotomy was asked in the NEET PG exam, intraosseous infusion image was asked in the NEET PG exam, amount of fluid given was asked 3 years back, pelvic binder was a INI-CET question this time, GCS scenarios and updates, many times they have been asked, and the mangled extremity severity score value which determines amputation has also been asked. Whenever we encounter a trauma patient, there are certain things which we need to remember. The information which we get from the driver or responder, you get missed, that is mechanism of the injury, what is the extent of injury, signs and symptoms, and the treatment given. From the patient, we get allergies. M is for medical history. M is for medical history if they are diabetic, hypertensive, taking any medicines. P is for past medical history. L is the last meal which they have taken and when was the last meal taken. And E are the events leading up to the trauma. So this is the information which we try to gather before the patient reaches the emergency. Now when the patient is being transferred, we should always remember that if you want to remove the helmet, then it is a 2-person helmet removal. Just remember this much, we don't remove the helmet, a single person cannot remove it, because if a single person removes it, you are not maintaining the cervical spine. So to ensure that the cervical spine is stabilized, 2 people are required. Now to transfer a trauma patient, we need to immobilize the cervical spine. So either we are going to transfer the patient in a supine position, and you can see that the head, thorax and the pelvis, head, thorax and the pelvis, that is strapped. So you strap at 3 places so that there is no movement, or the patient can be transported in the prone position. Advantage of the prone position is that you prevent aspiration, but never in the lateral position. You never transfer a trauma patient in a lateral position, and preferably the trauma patient is transferred on a hard board. Now when trauma occurs, there is a trimodal distribution of mortality. The first spike occurs at impact, and I can't save these patients because these patients die because of massive head injury and they are going to die on the spot. A lot of cases die within the first 1 hour after trauma. And what are these causes? These causes are airway obstruction, tracheobronchial injury, open and tension pneumothorax, acute circulatory arrest, hemothorax and tamponade. Okay? So these are the causes which can kill within the first 1 hour. So if we provide proper care within the first 1 hour, then we can reduce mortality due to these causes. That is why the first 1 hour is known as the golden hour following trauma. This you should know, the first 1 hour is the golden hour because proper care can prevent mortality due to these 7 causes. Late causes after a few days to weeks are usually sepsis and delayed head injury. Triage literally means to sort out. Triage means to sort out, and it is a color coding system where red is high priority, yellow is medium priority, Green are walking wounded, where you just do the dressings and provide them care and send them home. Black are the dead bodies. So this you should know for the exam. There has been one addition which I also want you to remember. So please remember, red is emergency or immediate care. These are causes within 1 hour. So those 7 causes which I told you within 1 hour, they all fall under the red category. So those are examples of red category. So yellow are the fractures, and these patients with fractures, we have to admit these patients and we have to stabilize these patients, but surgery can wait for some time. Green, I've already told you, are walking wounded, where you just give them first aid and then you send them home. The new category which has been added is blue. Blue is the expectant category, and this is for moribund patients. Moribund means those who are about to die. So we just make them comfortable, we give them pain relief, but unnecessary interventions are not done. And dead bodies are labeled as black. Now, in trauma patients, we follow the ATLS guidelines. ATLS is Advanced Trauma Life Support. Please don't confuse them with the BLS. BLS is Basic Life Support. In Basic Life Support, it is CAB, circulation, airway and breathing. Whereas in ATLS, it is airway, breathing, circulation and disability. So both are very different. In trauma, we do a primary survey. Primary survey is which is done immediately, and here it is airway, breathing, circulation and disability. Plus we look at the life-threatening injuries, which I have told you, those 7 injuries. Secondary survey is a detailed survey which is done once we have stabilized the patient. That is the secondary survey which we carry out. These life-threatening injuries, those 7 I had already told you in that graph. Airway obstruction, tracheobronchial injury are airway causes, breathing causes are tension and open pneumothorax, and the circulatory causes are the other 3, hemothorax, tamponade and acute circulatory arrest. Now the first thing in ATLS, that is primary survey, is the airway. Airway is always cervical spine followed by airway. I told you cervical spine is very important, because if you don't pay attention to the cervical spine, the spinal cord can get transected and the patient can land up with paraparesis or can even die. So whenever in doubt, we put a cervical collar, and that is known as a Philadelphia collar. Another way to assess cervical spine is the nexus criteria. And you need to know that nexus criteria is for cervical spine. You need to remember the mnemonic nexus. N is for neurological deficit, E is for alcohol intoxication, X is for extreme distracting neck injury, U is unable to speak, and S is midline spinal tenderness. So if any criteria of nexus is present, then we need to do imaging of cervical spine to rule out any cervical spine injury. So this we need to remember. So once we have taken care of cervical spine, then we move to airway. What are the signs of a compromised airway? So whenever you encounter a trauma patient in the emergency, you try talking to the patient. If the patient can speak normally, that means the airway is fine. So inability to speak, GCS less than 8, coma and severe maxillofacial injuries, these are all signs of a compromised airway, and in these patients we need to achieve a definitive airway. How do we achieve a definitive airway? We do endotracheal intubation, right? We do endotracheal or orotracheal intubation is done. Nasotracheal intubation is usually avoided, especially in head injuries, because if the base of skull is fractured, then your tube, if you put it through the nose, can go into the brain as well, and we don't want that. So that is why orotracheal intubation. But if orotracheal intubation fails, Then the emergency intervention is a needle cricothyroidotomy. This has been asked in the exam. You put a needle in the cricothyroid membrane, and this acts as an airway for 20 to 30 minutes. What is the image? Image of cricothyroidotomy. So this is the cricothyroid membrane, right? You enter in the cricothyroid membrane, you put in a needle here, that is needle cricothyroidotomy, which can be done. This only buys us time for 20 to 30 minutes, during which we have to do a tracheostomy, which is the definitive airway if orotracheal intubation cannot be achieved. This is a video laryngoscope which you can use, you can see where you are going. So I am sure as interns all of you must have intubated. This helps you in seeing where you are going and makes intubation easier. Cricothyroidotomy I have already told you. Tracheostomy you already must have seen. We make the tracheostomy in the neck, and this is an LMA, this is a laryngeal mask airway. This is a laryngeal mask airway which also we can use in trauma patients, and the advantage of a laryngeal mask airway is that less technical skills are required to put in an LMA as compared to an endotracheal tube. So, if you train even an intern to put in an LMA, they can do it easily in a trauma patient. Moving on to breathing, we look at chest examination and we do pulse oximetry, that is an adjunct, and we do a chest X-ray, pelvic X-ray and a cervical X-ray. Chest X-ray will tell you if there is any collection or pneumothorax or rib fractures. We will talk about fast scans which are also done in patients with trauma. We will talk about this when we talk about abdominal trauma. Moving on to circulation. So in any trauma patient, minimum 2 18 gauge IV lines, which are 18 gauge, green in color. So minimum 2 green in color IV lines are to be inserted, and how much fluid? 1 liter of crystalloid is to be given. Earlier it was 2 liters, now it is 1 liter. This has been asked many times in the exam. So when we give this 1 liter of fluid, we have already discussed, remember shock, we have discussed the responder, non-responder, transient responder. We have already discussed that, so I am not covering it here. Now, to give this 1 liter, I need an IV line, but just in case I cannot put in an IV line, then what do I do? So the emergency intervention, you have two. You can either do intraosseous infusion, or you can do venous cut down, I will show you the images. The image of intraosseous has been asked in the NEET PG exam. These are the emergency interventions. The definitive intervention is a central line which I have covered in nutrition. I have told you the most common in trauma is internal jugular vein, IJV. So you can see here, this is intraosseous infusion where you put in this needle just below the tibial tuberosity and you can give fluids. This is a venous cut down which we usually do in the great saphenous vein just anterior to the medial malleolus. We dissect the vein and we put in a tube directly inside the vein. I have already told you the ATLS update that 1 liter of fluid is now being given instead of 2 liters. So more judicious fluid approach. This question has been asked in NEET PG. There is another trial which has been mentioned many times. This is the CRASH 2 trial. This is the role of tranexamic acid in trauma. So if the systolic BP is less than 90 millimeters of mercury and or the pulse rate is more than 110, then we give tranexamic acid 1 gram over 10 minutes and 1 gram over 8 hours, right? And this reduces mortality in trauma patients. This was the question asked in INI-CET this year, that pelvic fractures, pelvis is an area where a lot of blood can accumulate, and if there is a pelvic fracture, there can be a lot of bleeding. So if we are suspecting that there is a pelvic fracture, we need to tie a pelvic binder till we rule out a pelvic fracture. Okay, so we tie a pelvic binder till we rule out a pelvic fracture. Now this binder can be a proper binder which you get, or if you're roadside and you don't have a binder, you can even use a bed sheet. And that is what they had asked in the INICET exam, that what is the first intervention if you encounter a patient with a suspected pelvic fracture. The answer was tie a bed sheet around the pelvis. Okay, so that is the correct answer. Damage control resuscitation, this I had covered in the shock module. Hypovolemic shock also I have covered this. I'll repeat it quickly. It is permissive hypotension, means we keep the systolic BP at lower limit of normal. The reason for this is that if I suddenly raise the BP, the tear in the vessel can also increase. So we keep it at the lower limit of normal. We minimize the use of crystalloids, use blood products in a 1:1:1 ratio to prevent coagulopathy, and early hemorrhage control should be done. Glasgow Coma Score has been asked innumerable times, GCS. Three things are taken into account, and this we are talking about disability. A, B, C we had done. This is disability. So disability is Glasgow Coma Score and pupillary response. In the Glasgow Coma Score, eye opening ranges from 4 to 1, verbal response ranges from 5 to 1, and motor response ranges from 6 to 1. You need to remember this for the exam. One more thing which I want to highlight is we always look out the best response. So supposing they give you a scenario, and this scenario has been asked, supposing they give you a scenario that the left arm can localize the pain, that is M5, but the right arm goes into abnormal flexion, that is M3. Which M will you take? You will take M5. We always record the highest value in M and the V score. The new category which is there is NT, non-testable. So eye opening also there is a new category, non-testable, if supposing you can't check the eye response. Similarly, in verbal response you have non-testable, and in verbal response when will you get non-testable? If the patient is intubated or there is a tracheostomy. So if there is a tracheostomy or the patient is intubated, patient cannot speak. In the old score, it was written as VT and it was given a score of 1. Now we write it as NT, non-testable, you can't give it a score at all. Best motor response. So best motor response, also I have told you if motor response cannot be test, it is written as NT. This is the GCS-P score. GCS-P score is Glasgow Coma Score minus pupil reactivity score. So GCS minus pupil reactivity score. If both the pupils are unreactive, you give a score of 2. If one pupil is unreactive, score of 1. Neither of the pupil is unreactive, means both are reactive, then a score of 0. So supposing the score is 10 and both the pupils are not reactive, it is going to become 10 minus 2, that is 8. This is the GCS P score. Now GCS mild head injury is 13 to 15, moderate is 9 to 12, and severe head injury is 8 or less than 8, which is why we discussed that anyone with a GCS of less than 8 or less than 8, you have to intubate because the airway is not stable. So this was regarding A, B, C, D. Now if you are asked any question in the exam, you will mentally picture A, B, C, D, and you see if airway is fine, then we move to breathing. If breathing is fine, move to circulation. If circulation is fine, move to disability. But if any one of these in this order is not fine, that is the first intervention which we are going to do. In a trauma patient, To examine the back of a trauma patient, we carry out a log roll. So log roll, 4 people are required to do a log roll, that means to tilt the patient to examine the back. In case the patient has a fracture, 5 people are required, but routinely 4 people are required to turn the patient safely to examine the back. There are certain scores in trauma. You have a revised trauma score. The revised trauma score takes into account 3 things: the Glasgow Coma Scale, systolic BP and respiratory rate. You don't need to remember these values. You just need to remember that these 3 things, GCS, systolic BP and respiratory rate, are taken into account. This is MES, this is Mangled Extremity Severity Score. The Mangled Extremity Severity Score, again the things which you need to remember: the type of trauma, shock group present, ischemia and age. Again, you don't need to remember all these values, just remember 4 parameters are included in MES, and this is the most important line which has been asked. If the score is 6 or less, then it is a salvageable limb, you can save the limb, but if it is 7 or greater, you eventually need to do an amputation. So that is what has been asked in the exam. So starting with abdominal trauma now, the key questions, PYQs which have been asked from abdominal trauma are FAST. FAST is extremely important, both FAST and EFAST. The workup of blunt and penetrating abdominal trauma, splenic injury management, especially the updated guidelines from Bailey. OPSI, which is a complication post-splenectomy, has been asked. Pringle's maneuver has been asked many times. Damage control surgery and the zones of retroperitoneal injury have been asked both in INI-CET and in the NEET PG exam. So certain one-liners in abdominal trauma, the most common organ injured is spleen. In blunt trauma also it's spleen. In children also it is spleen, right? So in children also overall it is spleen. Penetrating trauma, it is liver, more common than small intestine. Gunshot wound, GSW is gunshot wound, it is small intestine which is the most common organ which is injured. In seatbelt syndrome, it is the mesentery of the bowel, and deceleration injury, it is a DJ flexure or duodenojejunal flexure. So these are one-liners which you should know. Coming to a major important topic which has been asked many times, the workup of blunt and penetrating abdominal trauma. So the workup of blunt abdominal trauma, if the patient is hemodynamically stable, the first investigation which we do is same in both, in stable and unstable, it is FAST. And I will tell you about FAST in 2 minutes. What does FAST mean? We will discuss in 2 minutes. But the investigation of choice in these patients, the investigation of choice in a stable patient is CECT, contrast and CT scan of the abdomen, whereas in an unstable patient it is FAST. So you should know this for the exam. This is how we work up a patient with blunt abdominal trauma. Now what exactly is FAST? FAST stands for Focused Assessment Sonogram in Trauma. So it is nothing but an ultrasound which is done in the emergency room, and in FAST classically the probe is kept at 4 places. So you have, first is the epigastrium, first area is the epigastrium and this is the pericardial window, second is right hypochondrium, third is left hypochondrium, and fourth is suprapubic region to look in the pelvis. This is the classical description of FAST. Now if we call it EFAST, EFAST is extended fast. EFAST is extended fast, so it is 4 plus 2. What are the 2 sides? You have left and right thorax. So if you assess thorax as well, then it becomes extended fast, in which 6 places we keep the probe, whereas in regular fast the probe is kept at 4 places. So this is focus assessment sonogram in trauma. Now whenever we do this fast scan, you should always remember that if FAST is positive, you will see free fluid. Okay? If FAST is positive, you are going to see free fluid, and free fluid will appear as hypoechoic, as a blackish appearance or a blackish shadow, hypoechoic, that means fast is positive. This question has been asked in ionized CT where they've shown the image. Now fast, I've told you the full form. I've told you the probe is kept at 4 places and E-fast at 6 places. It detects free fluid in the abdomen and pericardium, will not reliably detect less than how much blood? 100 cc. So it detects 100 cc, does not directly identify the injury to hollow viscous, cannot reliably exclude injury in penetrating trauma, which is why you will see in penetrating trauma the guidelines for workup are slightly different. May need repeating or supplementing with other investigations, and it is unreliable for the assessment of the retroperitoneum. So please remember this. We can't assess the retroperitoneum because in front of the retroperitoneum is your bowel gas, and we know that ultrasound cannot go through gas. So that is why it is not a good modality to assess renal injuries or retroperitoneal injury. That was regarding blunt abdominal trauma. So I told you if fast is positive, then the patient goes for a laparotomy. And whenever we do laparotomy in trauma, we always do a midline laparotomy here, right? So always a midline laparotomy will be carried out. Penetrating abdominal trauma, the workup is different. If it is superficial to the peritoneum, then we will do local exploration and suturing of the wound, and this would be followed by CECT. But if there is a peritoneal breach, so this is the important thing, if there is a peritoneal breach, and how does a peritoneal breach manifest? It will manifest as either the omentum coming out or bile staining of the dressing, or there are signs of peritonitis. What are the signs of peritonitis? Rebound tenderness, guarding, rigidity. So if these signs are there, then we straight away go for a laparotomy. If you have a patient where peritoneal breach is there, even if the patient is stable, the patient lands up with a laparotomy. So like you see, omentum is hanging out here. In this child who had a young male who had a stab, omentum is hanging out. Even if the patient is stable, we have to carry out a laparotomy or exploration in this patient. Always remember, penetrating trauma, we never remove sharp objects which are impaled inside. We never remove sharp objects in the ER. They should always be removed in the theatre, and the reason for that is that this sharp object might be tamponading a vessel, right? But if you remove it in the emergency room, the tamponading effect goes away, the pressure goes away, and the patient can start bleeding immediately. That is why always remove them in the OT and never in the ER. Diagnostic peritoneal lavage, DPL, this was asked 5 or 6 years back. Since then, no questions have been asked. And what are the indications for DPL? This is done when fast is not available. That is what we do in unstable patients. So when fast is not there and you have an unstable patient, we will carry out a diagnostic peritoneal lavage. So diagnostic peritoneal lavage, we first aspirate. If 10 cc of gross blood is aspirated, it is considered as positive. If not, then we instill 1 liter of saline, and after instilling 1 liter of saline, we aspirate, right? So criteria are more than 10 cc of gross blood is aspirated, or 1 lakh RBCs per cubic millimeter, or more than 500 WBCs per cubic millimeter, or serum amylase more than 175, or the presence of fecal or food content. All this is a positive DPL, and patients with a positive DPL also land up with a laparotomy.